picture now is clinical anatomy of the head and the neck. So the clinical anatomy of the head and the neck, for you to be able to understand it very well, you have to take it bit by bit. If you now take the head alone, you discard the scalp, discard the skull, then you discard the face. If you take it that way, you should be able to say a lot of things in there. So if we now take the scalp, you know the scalp has how many layers? 5 layers. You get it? This is the S for the skin, right? C for cutaneous, what? Cutaneous connective tissue, right? Is it cutaneous or connective tissue? Connective tissue. So you have the connective tissue, which is the C. Connective tissue, dense connective tissue. Then A is for the glia aponeurotica. Are you clear? Glia aponeurotica. And then the P, the L is for the loose areolar connective tissue. And then P is for the periosteum, the membrane that is attached to the skull or the bones of the skull. Are you clear? These are the 5 layers of skin, of the scalp, sorry. So we have the skin, we have the connective tissue, which is dense, and then we have the glia aponeurotica, which is the A, L for the loose connective tissue or the loose areolar connective tissue, and the P is for the periosteum, surrounding the membrane, surrounding the bones of the skull. So now, since the skull has scalp over it, and part of the scalp is the skin, and you know all our hair emanates from the skin and the cutaneous, subcutaneous tissue, underneath the skin. Are you clear? So the skin, since it is just like a platform through which our hair come out, so obviously, the hair in our own head, it is very plenty, especially for women. And so it's just like if you now compare a single tree and a forest, which of them will consume more water? The forest will consume more water for the forest to continue to develop, right? So if you compare our head, where there is a lot of hair, and other places in our own body, you know that head must be well vascularized, because for the hair to come out, there has to be some nutrients. Are you clear? That nutrients come from nowhere but from the blood. So that means our skin of the scalp is well vascularized as a result of this hair around, for the hair to get nourished and grow. You will see some people with very thick hair. So the scalp is fully vascularized, and it also has a lot of sebaceous glands. The sebaceous gland is responsible for, bringing or secreting sebum, oily material from underneath the skin. The sebaceous gland is underneath the skin, and so it lubricates, the areas around the scalp. And so that is why, because the skin of the scalp has a lot of sebaceous glands, that is why it develops what we call sebaceous cyst. So sebaceous cyst is just like a cyst developing from the sebaceous glands around the skin of the scalp. So sebaceous cyst is very common, and the scalp can easily develop this sebaceous cyst. Similarly, certain infections from the fungus. You know what is fungus? The fungus, we call it unhuna da Hausa. So the fungus now, that's what we call tinea capitis. That is what we call makiru da Hausa again. So you will see that it forms something like a ring around the skin of our scalp. You get it? And so this round like infection around the scalp, that is what we call tinea capitis. You may also have boils. So the boils are just rashes of the scalp, whereby they have some pus inside them. Some they may be smaller, some may be large enough. Again, some of us, if they go to the barbing salon and they barb their own hair, they tend to develop some rashes on the head, what we call folliculus barbae. Because of the barbing you do, there are some rashes that develop in the scalp, and so these are what we call folliculus barbae as a result of the clipper. You barb one head, has some infection, you come and barb another person. And that is how we develop this folliculus barbae from the barbing salon. So you can have several infections affecting the scalp. And again, someone may have laceration along the scalp as a result of accident or as a result of endeavor fight when they use a knife to cut across the scalp. So once that laceration happens, the bleeding tends to be excessive. Why the bleeding is excessive? Because the scalp is well vascularized. A lot of blood vessels are there. And that is why when there is a laceration on the scalp, you see people bleeding a lot, because the scalp is well vascularized because of the hair that we do have. And so for you to be able to stop the bleeding on the scalp, you have to make some compression along the area of the laceration. If you can remember your head and neck very well, there are branches of what we call external carotid artery. The terminal branches are along, the lateral side of the head. And so if you now use your finger, you put this tip of your index finger just anterior superior to the tragus of your ear here. Then you press hard, you are going to feel a pulsation of an artery. That is the temporal branch of the external carotid artery, what we call superficial temporal artery. The superficial temporal artery is the one that goes up to branch and rebranch and supply all these areas around here. And so you will feel that artery pulsation. Are you clear? So this, if you want to compress the artery, you can come around the beginning of that artery to compress it. You get my point? And for you to be able to do that, the person can do it himself to compress this area, or you can tie a tie. Just get a tie, head tie, to tie around just like a turban. You turban around and then you tie it so that blood will not be going this side. Are you clear? To avoid the gushing of the blood out of this superficial temporal artery. So again, if the laceration, if it's just a trauma, like contusional forces, somebody bangs, somebody use a very heavy object like a metal to bang on the head. You see, some of the arteries may rupture inside without seeing the blood outside. So the collection of blood underneath the skin, that is what we call hematoma. So there will be a bleeding underneath the skin, and the bleeding can be either, underneath the skin within this connective tissue, or it may be underneath this loose areolar connective tissue. If it is underneath this loose areolar connective tissue, that is what we call subgaleal hematoma. That means the bleeding is underneath the loose areolar connective tissue. And because you know that in adult, we have a sagittal suture here. The periosteum divides this right part of the skull from the left part of the skull. So if there is a bleeding on this side, let's say there is a bleeding in this area, the bleeding cannot go to this side because of this suture that is here. So because the periosteum gets sutured across this sagittal suture there. So the bleeding here, the hematoma, the swelling, you see this side is swollen up very well, but it cannot go across this midline. Are you clear? So if it is this side, the bleeding here cannot go to this side because of this suture. Are you clear? The same thing when somebody has a trauma on the forehead, on this left side, it cannot go to this side because of the suture, this frontal suture here. Are you clear? Good. So that is hematoma collection as a result of injury to the blood vessels inside the scalp. So the compressional force, you can apply it along this area where I told you the landmark for that superficial temporal artery, where you make a head tight around the head itself. So you can also have what we call caput succedanum in the skull. I'm sure some of you who have born some children, the women, when you born a child, you see that the child comes out with a swelling on the head. When you touch the swelling, you will feel it is fluctuant, just like water inside. This is as a result of the trauma, birth, we call it birth trauma. So when somebody now, the birth canal maybe is very small, so birth trauma can be as a result, because at times the midwife that is collecting the delivery of that baby, she may use a compressional forces to bring out the head out. Or if it is in the clinic, doctor may use what we call forceps to bring out the head. So by the time, because the forceps is just like a fork of our spoon, so you grab the head, you drag the baby out of the vagina like that. So as a result of that forceps, the pressure you apply on the head, the guy may have this accumulation of serous fluid in the head, but it resolves on its own without having any treatment. That is what we call caput succedanum, accumulation of serous fluid in the scalp. So again, you all know that when a baby is born, there are some gaps that one can see in the top of the head, very wide diamond-shaped gap in the anterior part of the superior part of the head. This is what we call anterior fontanelle. At the back, there is another gap which is triangular, and that is what we call posterior fontanelle. This anterior fontanelle, it is the junction, the gap between the coronal suture, which is this one, and then the frontal suture, which is in the front, and the sagittal suture posteriorly. So here you have this diamond-shaped, gap, which is very wide anteriorly here. Posteriorly, we have this lambdoid suture, which is this one, and then you have this sagittal suture. In between them, there is this triangular space, what is known as the posterior fontanelle. And you know that in children, these gaps, the sutures, are not closed. So you will see that even if there is expansion inside the cranium of the baby, the head can expand very well, because these sutures are still not fused, so to allow for the increase in the intracranial pressure. But with time, these sutures will close, so that there will be only lines you will see. There will be no spaces in between them. And so these fontanelles also tend to narrow down and close at the end. This anterior fontanelle, because it's very wide, it takes a longer time to close because it is a wide gap. So it takes about 18 months, 1.5 years in children to close. While this posterior fontanelle, because it is small, it takes only about 6 months to close. So that by the time the baby is 1.5 years, all these fontanelles are closed. In children, this fontanelle, when somebody is dehydrated, especially in the village where there is no enough food, and amidst this very terrible hot weather, the baby may be dehydrated. Signs of dehydration can be noticed in the baby in the anterior fontanelle, because you are going to see that the anterior fontanelle now sinks down. So it sucks down you see that there's a depression there going down. That indicates signs of dehydration of that baby. When you see that that fontanelle bulges up, when you find that it is just swollen up like that, and then it is very tense, that indicates the signs of raised intracranial pressure. So there's an increase in intracranial pressure, what we call ICP. So that is one of the areas where you can check for the sign of meningitis. Baby that has meningitis has raised intracranial pressure, and by so having, the anterior fontanelle and the posterior fontanelle, they get tensed. They bulge out like that. So when you touch, it's very tensed. And that is one of the signs of, raised intracranial pressure. Or at times, the skull itself may get some injuries. Like during fight, somebody may give a blow to the lateral side of the skull, and here on that lateral side of the skull, there's what you call pterion. Pterion is just an area where you have union of 4 sutures, and the bone around there is just the area there is in an area where you have about 4 bones uniting. You have the temporal bone from below, you have parietal bone from above, you get it, and then you have temporal bone from the front here, and then you have the frontal bone from the front. Are you clear? So you have this area there. So once, and the area there where the 4 bones unite, once you keep passing a blow on this side, this area can get fractured. And deep within it, there is what you call meningeal branch of the maxillary artery. Maxillary artery, they are the 2 terminal branches of the external carotid artery. So it gives this superficial temporal artery going up to supply the scalp, and then the maxillary artery goes inside to supply the maxillary area of the face. So the maxillary artery gives a branch that supplies the meninges around the brain, and that is what you call middle meningeal artery. So once you give a blow to the lateral side of the skull there, you may fracture this pterion area. We call it pterion, like this. So this pterion area, it may injure the middle meningeal artery, and there will be a bleeding in there, what we call epidural hematoma. Call it what? Epidural hematoma, because this middle meningeal artery is being ruptured as a result of blow to the pterion there. So again, the blow or the accident may affect the base of the brain. The base of the brain, the base of the skull. The base of the skull now, is a very complicated base. So once that side breaks, you can have what we call rhinorrhea. Rhinorrhea means bleeding, bringing out serous fluid from the nose. So rhinorrhea, you will see the CSF, cerebrospinal fluid, it surrounds the brain. So once there is a fracture at the base of the skull, the CSF may come out from the cranium, pass through the nose, and somebody will now be draining CSF from the nose. And that is what we call rhinorrhea. So after accident, when you see somebody bringing out water from the nose, that is not ordinary water. It's cerebrospinal fluid coming out. So that indicates that that person has fracture of the base of the skull. You get it? And so these are some of the things that you people should get to know. And maybe I will have a break now. Later on, I will continue with other parts of the clinical anatomy of the head before I now go to the neck.